This is the Rural Regional Behavioral Health Policy Board for March 3rd, 2026.
Oh, wait.
And I will have Valerie, just so we have it on record, and the meeting is being recorded, but so we have it on record of the members that are present and those excused. Valerie, if you would, please.
Chair Fergus Loffridge.
Present.
Brooke O'Byrne.
Here.
Senator John Ellison. Dr. Erica Rist.
Here.
Robin Dunkhorst. Wendy Nelson.
Present.
Chris McCann.
Present.
Patrick Rogers.
Present.
Sarah Dearborn is excused. Judge Montero is excused, and Sheriff Jerry Allen is excused. Chair Fergus, we do have a quorum, and I will note when Robin Dunkhorst joins the meeting.
Very good. Thank you so much. Okay. Well, thank you everybody for joining. Let's move this along and go into our public comment period. If those wish to speak, I guess I have to read this. If there's a member of the public that would wish to participate by phone, dial 669-900-6833 or 719-359-4580. And when prompted, enter the code 029225. Due to the time considerations, each individual offering public comment will be limited to no more than 3 minutes. Do we have anybody from the public that would like to speak at this time?
Fergus, I'm seeing Laura Yanez would like to speak.
All right. Let's go right to Laura then. Thank you.
Hi, thank you very much. My name is Laura Yanez, for the record. I wanted to speak about a couple of things. One is I wanted to make the board aware that NAMI Western Nevada, in partnership with some of our local jurisdictions, will be restarting the virtual crisis care program that is available to law enforcement. That if a law enforcement officer has contact with an individual they suspect is experiencing a mental health crisis, they can activate a tablet and have an on-site assessment done with a recommendation as to whether somebody can remain safe in the community, or whether they should be taken to a hospital. So we are restarting that program and slowly launching throughout this region. In addition to that, we will be launching a program that's called Freedom Bridges, and it is a peer support program for individuals that have been judicially involved in re-entering the community. It is a program that can start while they're incarcerated, and we're working with the jails to ensure those appointments. And then once they're released, the program goes for 12 months post-release based on the individual's desire. So we are launching that program, which also brings me to the final point I would like to make, is that one of the challenges that we are having with our peer support programs is that we're being told we need to bill Medicaid when appropriate, meaning when an individual has Medicaid. However, one of the challenges is that we are employing people who themselves have been judicially involved and are living in recovery right now. And we're running into some challenges around being able to bill Medicaid for those individuals, yet being judicially involved and having that lived experience with mental health and or substance use disorder and the criminal justice system is one of the requirements of the job. So I just wanted to bring it to the attention of this board that we are facing those challenges as we look at rolling out a strong peer support program in Frontier, Nevada, with a very limited workforce, that some of our most talented individuals that could be supporting these efforts are actually being excluded from the ability to work in that field because of the need to bill Medicaid. So those are my 3 announcements. 2 very happy, 1, please help us.
Thank you, Laura.
Fergus, I would like to note that Sheriff Jerry Allen is on the call. Sheriff Allen, are you able to unmute?
I believe so. Can you hear me now?
We can. Thank you so much.
Gotcha. We just needed to get your wonderful voice on the recording, so we know you're here.
Sounds good.
Hold everybody accountable, right? Okay. All right. We're in the public comment phase. Are there any other public comment at this point? Not seeing any other hands or not hearing anyone. Let's close that and let's move into item 3, which is the approval of the minutes. My screen went. I don't have the current agenda up, but
My apologies. I'm trying to fix that right now.
thank you. I have my draft here for the June 4th meeting minutes. I believe those all went out for the June 4th, the December 3rd, and December 8th meetings were all distributed to the board members.
Fergus,
We'll take
for the record, this is Valerie. A correction. I was not able to get the December 8th meeting minutes on time, so only the June 4th and December 3rd meeting minutes were presented to the board for review.
Okay, so let's go item number 3, which will be the approval of the June 4th meeting minutes. If we entertain a motion on that, if everybody's had a chance.
I so move. This is Wendy Nelson, that we approve the June 4th and December 3rd minutes.
Okay, there's a motion and any second. Any other question?
This is Patrick Rogers. I'll second that, please.
Thank you, Dr. Rogers. And all those in favor, signal by saying aye. Aye.
Aye.
Any opposed? Hearing none, that passes unanimously. Let's go to item number 4, which is the December 3rd meeting minutes. Entertain motion.
This is Patrick Rogers, and I will move to approve the December 3rd meeting minutes.
Okay, there is a motion and will anyone like to second that, please?
This is Erica Rist. I'll second.
Okay, thank you, Dr. Rist. We have a motion and a second. And any opposed? Or excuse me, all those in favor, signal by saying aye.
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 Any opposed? Hearing none, that is the approval of the December 3rd meeting minutes. Item number 5 of the agenda, the December 8th meeting minutes will be tabled until next meeting when we can get those out and act upon them accordingly. Next item on our agenda would be item number 6 is review and possible approval of the proposed meeting schedule for this wonderful body of individuals through the remainder of the calendar year 2026. Valerie, I'll turn this over to you. You've done the legwork on this and putting it all together.
Good afternoon. For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. So the schedule that I'm proposing here for you today is based on feedback garnered from individual board members regarding any reoccurring gaps in their schedules that we could probably squeeze into. I did get feedback that board members seem to be fine with meeting monthly until we get the board's bill draft requests submitted this summer, and then thereafter move to a bi-monthly or quarterly schedule. And so with that being said, the proposed following meetings would fall for the rest of the calendar year. That would be April 7th, 2026 at 2 p.m., May 5th, 2026 at 2 p.m., June 2nd, 2026 at 2 p.m., July 7th, 2026 at 2 p.m., August 4th, 2026 at 2 p.m., which you guys can cancel if you would like, if you have all of your business done and the BDR is in. I know that there's a lot of people out on vacations in August to get right before school starts. So just throwing that out there. The next meeting would be October 6th, 2026. Usually about that time, we can catch up with other presentations that maybe the board was not prepared or was not able to hear due to BDR work and things happening over the summer. And then December 1st, 2026, which should be about the time that we receive the draft of the bill language for the board to review. In past years, we've received that draft towards the end of November, sometimes the first week in December, and had until about the end of the first week in December to submit any changes. So that would give this body an opportunity to review any changes that you would like to make before the final draft language is sent to the LCB for drafting of the bill. I would like to note that these meetings all fall on the first Tuesday of the month at 2 p.m. That seemed to be a recurring time slot that worked for board members who were able to respond to the survey. And then also, I would like to propose possible additional meetings and having concurrent meetings of all of the regional behavioral health policy boards for the purpose of collaboration, particularly in preparation for the upcoming legislative session, and sharing a mutually beneficial information as you did in December. That would look like one meeting scheduled sometime this summer, likely somewhere between June 1st and August 31st. About that time, all boards should have their BDR concepts at least selected, if not completely hammered out. And one meeting scheduled during December 2026, as you did last year, where the boards could talk about other or share other information and maybe talk about their respective bills for the 2027 legislative session. So that is my proposal of the board schedule.
Are there any questions for Valerie at this time? This is an action item. We'll entertain a motion for the approval of the dates as submitted by Valerie after doing the extensive survey of the board members.
Chris McCann here. Those dates look good to me, so I'll motion.
Thank you, Chris. There is a motion on the floor. Will there be a second, please?
This is Brooke O'Byrne for the record. I'll second that.
Thank you, Brooke. We have a motion and a second, and all those in favor signify by saying aye.
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 Any opposed? Hearing none, that passes unanimously. Thank you, board. That is very important that we get these dates plugged into our schedules and keep us going forward. Next, we'll move on to item number 7, which is the review and update of the Rural Regional Behavioral Health Policy Board's policy priorities for the calendar year 2026. I'm going to again turn this over to Valerie. She's done the work on putting this together. This is a summation of last year, and then with some things thrown in there for 2026. So Valerie, floor is yours.
Thank you, Fergus. Again, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. So what we've done here is I built a working document for us to work through your policy priorities and see if there are any updates you would like to make to past policy priorities for the calendar year 2026. The reason why we go through this is to, first of all, guide the selection and development of your bill draft request for the upcoming legislative session in 2027. Communicate any needed changes within behavioral health systems and provide meaningful recommendations to state and local stakeholders and policymakers alike. So when we have these finalized policy priorities, we can publish these, send them out to stakeholders, and they know exactly what you're looking to see across the board. Assist myself in providing guidance to stakeholders at all level. So this helps guide me as to what your priorities are and to focus on that type of TA. And then to develop and define the current and future scopes of my work as well. So when I'm working with the state to develop my scope of work for each fiscal year, I look back to the policy priorities of this board and look at what aligns really well so that I am truly working to move a lot of your strategies and your priorities forward. So first, we're just going to review your previously approved policy priorities from 2025. And then we're going to kind of all at once identify what we want to remove or table if there's any new priorities or strategies you would like to add, and then identify any additional edits to the priorities themselves or recommended strategies. And then last but not least, Fergus will ask you guys to take some sort of action because this is another action item. So part one, kind of the 20,000-foot view. The policy priorities here are pretty broad, but that's because the behavioral health system is pretty broad. And so we've got them grouped into general kind of areas. So access to care, which includes physical access, being able to get somewhere, financial access to care, and then availability and capacity of services. It's great if there are services next door and you can afford them, but if they're full and can't take you, that's not helpful. Insurance, limited coverage of the number of services or the types of services that the insurance will pay for. Insurance process red tape for providers entering the network system or providers connecting clients and patients to the type of care that they need. And in this, we're really talking more about private insurance more than Nevada Medicaid at this specific point. Limited reimbursement for providers. This is something we keep hearing coming up year after year. And then barriers to in-network care. So there have been described barriers for providers who want to join insurance networks for provider shortage areas such as rural Nevada. But unfortunately, those insurance companies tell them that the networks are full, which makes no sense when it's a provider shortage area. Workforce development includes the number and type of providers available. Training in the best practices in telebehavioral health. As telebehavioral health becomes more and more accepted by a lot of clients and is leaned on a little bit more heavily, we want to make sure that it is used appropriately and implemented in accordance to best practices. It's not always the most appropriate type of care to be using given depending on the circumstance. And then culturally competent, respectful, and age-appropriate practices. Culturally competent, that can refer to a lot of different things. The example that I like to give is if some sweet old rancher finally goes in and seeks service, if it's an urban person who maybe is a vegan and has an issue with the fact that they're a rancher, that's not going to be a great match and may not be 100% culturally competent. So culturally competent goes a lot of different ways. Respectful and then age appropriate. A lot of our seniors aren't terribly comfortable with telebehavioral health practices, and so we want to make sure that we're not leaning on telebehavioral health for some populations that may not be comfortable with it or largely uncomfortable. Quality of care is always a concern. We want to see improved care transitions from one type of provider to another. We would like to see improved communication among providers when appropriate and always being HIPAA compliant. And increase safeguards to the quality of care. So improved feedback loop and means for people to identify ways or places, what am I trying to say? Identify places where the ball was dropped and making sure that there are ways to close any gaps where people may be getting inappropriate care. And last but not least, supporting local efforts. So collaboration and support for aligning efforts with local coalitions and agencies, grassroots efforts and things that come from local communities usually have a lot more vitality and staying power because of the ownership amongst the local community. And so we want to make sure that we are supporting evidence-based, culturally appropriate practices that local coalitions and agencies may be moving forward. Support best use of opioid settlement funds. Those funds have very specific things that they can and cannot be used for. And so we want to make sure that those are being used appropriately and maximizing kind of the bang for the local buck. And expansion of the local behavioral health task forces. We already went through a lot of the details of the policy priorities. This was sent out to the board members last week. And so that being said, I'm going to skip down, unless anybody would like to go over any further detail. I'm going to skip down to this next section where we talk about the specific detail and any changes the board members would like to make, starting with priority 1, access to care, and sub-priority physical access. The detail here being safe, affordable, non-stigmatizing, and timely transportation, particularly to and from intensive treatment, is a chronic issue creating barriers for rural community members seeking care. Physical distance from care creates logistical issues. Being able to schedule care during times that patients can make in a timely manner is another physical access barrier. And so, board members, is this something that you would like to keep? Is there anything here that you would like to change or remove? Anything that you would like to add for this upcoming fiscal year?
Valerie, this is Wendy. Out here, that is a huge issue still. Obviously, we don't even have a bus. We don't have a train that stops here. We don't have an Uber. And so it has become a big issue. And we try to work with like our senior center right now and the hospital and things like that. But that is just a huge issue for us out here still. So I'd like to make sure we can keep that.
Okay, thank you. Any other comments or changes on this? Oh, Patrick?
Yeah, I think I'll kind of stand behind what Sonia just mentioned. I have heard, and correct me if I'm wrong, but oftentimes patients that need to be transported for an inpatient from the rurals to, let's say, like Las Vegas, that will be paid for to get them there, but not paid for to get them back home. And I think that to me, that's kind of very, and it's nice now that the hospital has, in Elko at least, has an inpatient unit there, but I don't know, if we're still transporting people. But I think that's something that needs to be in consideration, is that when it is mentioned that it is paid for primarily by Medicaid, it doesn't mean that it actually gets it paid to come home. And I think that's something that needs to be mentioned or in there.
That is correct. There are, I believe, no necessarily requirements for people to be transported home. My understanding is that one of the MCOs does have some contracts in place for behavioral health transport. I'm not certain if it is appropriate for people in crisis, which would require a secure behavioral health transport scenario that's elevated from kind of the more general. But yeah, I don't think that there's anything in place for return home trips, really. So
Valerie, the key word there would be repatriation to their home community. It's a common phrase used in our disaster planning in transport of critical patients.
If I could jump in, my name is Cindy Gates, and I'm the director here at the Behavioral Health Unit at NRH Inpatient.
Cindy, this is a statutory board, so if you want to raise your hand, Fergus Chair Lawfridge can call on you for clarification, but until public comment, there isn't any other legal opportunities for public.
I apologize.
Thank
you for that. Any other comment on from our board on the physical access sub-priority there? Good points being made from Wendy and Patrick. Let's move on. Let's keep this moving, Valerie. In the interest of time here, we got a lot to go through.
All right. So financial access. Some insurance companies may still not provide adequate coverage for necessary care. Insurance payer type may affect a patient's ability to access care if providers cannot accept that type of insurance. Some patients may not have the ability to meet copays for treatment, particularly for specialized providers or prescribed medications. Additional expenses associated with accessing treatment, such as purchasing fuel to drive services or drive to services, may be beyond some patients' financial ability and others. So board members, any comments?
There's a lot rolled into that. And different subcategories of the subcategory, but all important areas that board. What's your feelings, thoughts? Just say move it.
Yeah, we're seeing a lot of that actually, people talking about that because we run the action agency out here for 3 counties in the frontier area, and we're hearing a lot of that actually. It's a big issue still, so that that hasn't changed.
Wendy, with that being said, are you making progresses in those areas, or are you hitting resistance from the insurance companies?
You know, we just try to help navigate and refer. And so what we're finding right now is that we're trying to make sure we're connecting them with access to, you know, the different agencies that are here. So we actually are housing people here so they can answer questions, you know. CareSource and Silver Summit, we actually have them in all, I think 2 of our 3 offices. But as far as like financial things, we've been trying to figure out how to access other funding to even help fill that gap. It's just still a big issue, but yeah, it's a sticky wicket because there's really not a lot of things we can do as far as like actually helping in that area. So.
So I'm hearing we keep this for going forward. Okay, next, Valerie.
All right, so the next subcategory of access to care is availability and capacity of services. The chronic lack of providers of all types, but particularly those who could provide services for intensive care, co-occurring conditions, and/or special populations, creates additional barriers to access and care. Members of the board and the rural RBHC have been notified of the inability of providers to join insurance networks, even in documented provider shortage areas. That is it here.
Now this was in 2005. We identified this, and are we still, those that are in the delivery, are you still, providers still seeing this? Are we still obviously in a shortage? Are we having trouble with getting networked? I've heard some problems with some of the MCOs not getting networked, and then also with some private insurance. This is one we want to keep on the radar screen.
We obviously out here have a chronic lack of providers of all types. So out here, I mean, you know, that is what we have. We just have a chronic, and it's hard to keep good folks. You know what I mean? We've seen some turnover out here in some of our counties. And that's really tough because when you have a doctor, for example, that's been in a community for a really long time and they leave, it just throws the whole apple cart out of whack because, you know, they know their whole history, and I mean, it's just, so we've seen a lot of that. So yeah, it's definitely an issue still.
Sure, and I would venture to say that there's some inroads being made in, as Patrick alluded to, with treatment facilities in Elko, larger population center, but it's like that county, that close catchment area. It's not taking into consideration all of the other or other smaller rural and frontier counties. So there's definitely a lack of providers out there and network. Okay. Hearing nothing else on that one, Valerie?
All right, moving on to priority 2, insurance, limited coverage. Some payers may only cover a limited number of sessions with a provider. Many patients experience limited or lack of coverage for, quote, non-emergency, secure transportation, or emergency transportation to services. The board will support current and planned efforts to remove barriers to care for rural residents covered by public payers, including Medicaid.
There's inroads being made with the MCOs as far as transportation services, but again, we alluded to that, of whether they're non-emergent or emergent, and whether they need to be secure car or whatever that might be. But there is also limitations to the number of sessions with a provider that might be allowed. And so you're capitated at, okay, we can get you in here, but you're only going to get 6 sessions. Well, what if you're not? you need 8 or 10. How do we go back and re-get, and renegotiate that? So that does need to be addressed with public and private payers.
And Fergus, I would make the recommendation that we remove by just public payers, including Medicaid, and instead say by both public and private payers.
Agreed. As you were highlighting that, I was thinking it. So yes, absolutely. Yeah, I just had this conversation with a facility, a behavioral health practice this morning that the insurance companies payers basically have been the ones controlling how behavioral health services are delivered in the state of Nevada for far too long. And hopefully the Nevada Health Authority in their new resurrection will take a more active lead in that, to also weed out some of the nefarious players that have been skimming the money off of, and I'll say it very bluntly, it's happening. That's my personal soapbox.
Anything else for limited coverage? Fergus, should we move on to the next one?
Yep, keep moving.
Okay. Insurance process red tape. The board will support or advocate for the reduction and streamlining of procedural barriers, such as onerous prior authorization processes for appropriate and timely treatment and services. I haven't heard as much about this recently, but I am also not a provider. And just because I don't hear about it doesn't mean it's not happening. So, board members, thoughts on this piece?
Yeah, there prior authorization has become a sticky wicket in this whole new development of the Medicaid model, and insurance companies are quite there. Are also private insurance is in that same sticky wicket, so it can create some barriers. So I think it's important to keep this on the forefront.
And I'd like to add to that as well. Just so my husband is in a school district and out here, and they have insurance that requires a prior auth, and so you have to go to who would be your primary care out here. So you can't get in for sometimes 1 to 2 months. So then you can't get in anywhere, and you could have a real emergency going and they aren't going to cover it. And so it's going with regular insurance, and it's just a real problem just because of how it's functioning out here. So
Valerie, this is Erica Rist. I can verify from the provider perspective that this is an ongoing issue. And another issue sometimes is insurance companies coming up with certain requirements. I'll give you an example. For autism, recently, a number of insurance companies are requiring that a specific assessment tool is used to make the diagnosis. And although from a clinical perspective, it's not a requirement to use that tool, but they're using that tool as a barrier because it's a very expensive tool, and people have to put in hours and hours to get certified to use that particular tool. So it's just an example of the red tape that's used to deny services.
Okay, so is there anything that we should change in this language to discuss some of those additional pieces that are being thrown in? Or does this capture it?
you could possibly add in there with the prior authorization processes and screening mechanisms for appropriate and timely treatment of services. That might get to what Dr. Riss was speaking to.
Yeah, trying to figure out a concise way to summarize that.
And clinically unnecessary screenings and or clinically unnecessary steps.
Requirements, maybe.
There we go.
Does that work for you, Erica?
Yeah, clinically unnecessary requirements in order to qualify for services or something like that.
Okay.
Yeah, I will. I'm just going to mention on this. I'd spoke about that with the two providers coming in when they were trying to vie for the contract before they were awarded, and telling them that we have a real problem with getting into a doctor to get referred, and they were honestly really surprised by that. and so that really surprised me that they were so surprised. So I just thought I'd add that in there.
All right.
Okay. Let's keep this moving because I got a 3:30 that I got to be on.
Limited reimbursement for providers. Many insurance providers do not reimburse adequately for services, but most notably CMS and Nevada Medicaid reimbursement is historically low. The board will support and advocate for efforts to improve reimbursement efforts underway and in the future. A comment on this is I would recommend that we keep this and maybe specifically point out, I've been hearing a lot about outpatient service reimbursement for both private payers as well as, of course, Nevada Medicaid. But I'm hearing that outpatient is causing businesses to potentially close down. I'm seeing Patrick's hand up.
Yeah, thank you. I think that I would just add to this as maybe as a bit of a validation is that in the rurals, it becomes extremely difficult because we do have a recruiting problem and a retention problem of providers out there, and we have to compete with the urban areas to recruit and retain staff, providers in the rural areas, and that becomes very, very difficult when the reimbursement is so low. So it does affect the ability to not just keep the lights on, but also to recruit and retain staff to these areas, providers to these areas.
All right. So what I have here is the low reimbursement rates negatively affect the ability of rural and frontier provider organizations to recruit and retain clinical staff necessary to meet community needs.
Yes. Thank you, Pat. This is Patrick.
Yeah.
Okay. Anything else on this one? Sorry, go ahead.
I would say that the funding for providers, to my understanding, has progressively decreased over the years. And I don't know what methodology that CMS and Nevada Medicaid are using to determine what that fee, that reimbursement fee might be.
Yeah.
So I think that needs to be explored. Why do we keep cutting those costs?
And private insurance payer parity is something that has been a very hot topic in a lot of conversations recently. And I have also recently heard that again, going back to even just the outpatient clinical reimbursement for CMS hasn't been updated in, I heard 13 years. I don't know if that's accurate or not, but that is what I heard. Um,
It's gone down about 60 some percent.
yeah.
What was the number that was tossed out to me the other day?
So does this addition to this language over here cover all those bases, or is there anything else that we should add or change? All right, I'm not hearing anything, so I'm going to go ahead and scroll on down to barriers to in-network care. As noted above, some eligible providers are not being allowed to join insurance networks, which claim the networks are full, regardless of whether or not the provider will be serving a recognized provider shortage area. Is this something that you would like to keep on your policy priorities for this calendar year?
This is Patrick. I would vote to keep that on there, even though it's not just to the rurals. This is a statewide issue, and I think it needs to stay on there.
Absolutely.
Yep.
Okay. Anybody else? Last call? All right. Moving on to workforce development. Some cool new resources and availability, and a lot of focus on this during last legislative session and with the Rural Health Transformation Grants. 40% of the first fiscal year's funding being designated towards workforce development. Of course, that is both healthcare and behavioral health. There's definitely some new opportunities coming down the pipe. So that being said, sub-priority 1, number and type of providers available. The detail here is proper resources must be allocated to support statewide efforts to educate and place providers in shortage areas across the state. The board, Rural RBHC, and other bodies should focus on resolving inefficiencies and challenges related to provider licensing and credentialing. Thoughts on this? For workforce development. Any changes?
We're making progress. There's a lot of attention to workforce development. But Valerie, you've heard me say this before. We can train and train and train and we can put the people out there. But if they find that when they get out there that they're not being reimbursed for their services adequately, they're going to move on. So it's kind of a catch-22. We can pump that pipeline full. And that's what they're working on. The rural transformation is working on that. We've had conversations about this, but they're not grappling with that parity for the provider organizations.
Okay. All right. So any changes? All right, hearing none, I'm going to move on to training and best practices in telebehavioral health. The detail here is to ensure providers who are working with clients via telehealth mechanisms are trained in best practices for telehealth treatment for behavioral health services. Is this something you would like to keep? Anything you'd like to change on this? I would recommend potentially adding some language regarding the use of telebehavioral health in crisis settings. Since this is something where we do have several programs either in place or we're exploring different things related to the use of telebehavioral health mechanisms. And some of the feedback I'm hearing from local level stakeholders is particularly with the rollout of the Nevada crisis system with 988 is sometimes there are hiccups where someone is in a place where they are being triaged to a telehealth service when they are maybe in a place where care is so urgent that they need eyes on them at some point, or eyes on them immediately. And so I would recommend maybe looking at adding some language regarding use of telebehavioral health in crisis services. Telebehavioral health can be very appropriate, specifically programs like the VCC program that Laura Yanez mentioned during the public comment period. For that, there has to be another person present to have their eyes on the person and connect them via the tablet at the time of that first initial encounter, which is kind of where that hiccup with crisis services is that I'm hearing. Board members, what are your thoughts?
This is Patrick Rogers. I would support that, Valerie, as a clinician who actually does telehealth. I think, we're starting to get to the area that telehealth is becoming very much of a norm, and I think it's kind of getting there. But I think you're spot on with understanding when somebody's in crisis, and I personally have struggled with that when there's somebody that's been in crisis and I'm doing telehealth. That is a problem. So I think targeting the crisis intervention via telehealth is spot on.
Okay, perfect. And I know that sometimes there's not always clear protocols for those pieces. So maybe something along the lines of this includes identifying proper protocols for including in-person contact during crisis scenarios to maintain patient safety, client safety, contact when necessary. Okay, so this includes identifying proper protocols for including in-person contact when necessary during crisis scenarios to maintain patient safety. There's a lot of things kind of thrown into that. Any thoughts? Patrick, is how you go on and off mute.
Yeah, no, I was just, you were kind of, it sounded like you were questioning patient safety or client safety. It kind of depends on the setting, but I think you've worded this nicely, and I would run with that.
Okay. Anything else from board members? Okay. All right. Culturally competent, respectful, and age-appropriate practices. Already discussed this, but providers in rural communities engage with people from diverse backgrounds, ethnicities, religions, and age groups. It is vital that these providers understand not only basic tenets of cultural competence, but also culturally respectful care and/or age-appropriate care. Any changes, additions, removals? Erica.
Yeah, I mean, this one is just good general practice. I'm not sure that it necessarily is different for people in rural areas as opposed to people in urban areas. So if we're looking for ways to condense or slim down, this might be one that I might suggest taking out.
Okay.
I think a number of the other priorities are much more pertinent and specific to rural regions and also more pressing, but that's just my opinion.
Okay.
Yeah, I would agree with that.
Okay. All right. Moving on. Priority 4, quality of care. Improved care transitions. There is a dire need for improved systems to ensure patients are connected to the care they need in a timely manner, regardless of who is staffed at various organizations. Major improvements are needed in discharge planning to protect the health, well-being, dignity, and continuation of care for patients when they're the most vulnerable. Now, this specifically names discharge planning because that is an area where I had been hearing from stakeholders that things were going awry, particularly from discharge planning from organizations outside of the region, for residents who of the region we serve. So that being said, I don't know if we want to, instead of maybe saying discharge planning or like discharge planning and warm handoffs, care coordination, because it's as the 988 and crisis response system is being built out, there's still hiccups between different transitions of care. That isn't necessarily discharge. Board members, thoughts? Anybody?
Valerie, it's Erica. I think this is a really critical issue. A lot of times patients end up getting readmitted very shortly after a recent hospitalization just because the discharge planning was not good.
Okay. So shall we keep it as is?
I think so.
Okay. Any opposed? All right. All right. Improved communication among providers. A need for HIPAA-compliant platforms used by all providers for the coordination of care. Increased use of business agreements or MOUs among various agencies and providers for specific coordination of care. Expansion of assisted outpatient treatment, AOT, and or assertive community treatment, ACT programs for persons needing intensive care in specific communities. And for those of you who are not aware, AOT and ACT are high intensity service programs. I believe ACT or ACT is provided by Certified Community Behavioral Health Centers or CCBHCs, such as Vitality. The purpose of these programs is to meet the client where they are, whenever they need the assistance, and it's much more intensive than regular outpatient treatment. These are programs that are appropriate for people who are unhoused or who have housing instability, transportation issues, et cetera, because they usually include going to that person. AOT is ACT is completely voluntary. AOT is court ordered. And so from my understanding, and the clinicians on the call, please correct me if I'm wrong, but those are the primary differences between those two programs and the general gist.
This is Patrick, and yes, you summed that up well. I think this is a great follow-up to the discharge planning because sometimes not having the HIPAA compliant platforms make discharge planning when you're going from an inpatient to something that's more of an IOP type of setting is critical. So I think this is a good follow-up to that discharge planning piece.
Perfect. Thank you. Do we have any changes that we want to make to this? All right, not hearing anybody jumping up and down. I'm going to run down to the next one, increase safeguards to care quality. The board will support programs to evaluate and improve the quality of service provision across the state, but most pointedly in the rural region. I would think that this may become even more important with the Rural Health Transformation Grant funding coming in. Anytime there is kind of historically, when there is a large amount of money available, while there's always many organizations trying to do the right thing, there may be some organizations who try to take advantage of any sort of funding chaos, or try to maybe not do the best that they should be doing, as we've seen in some of our communities. So I think that having these particular, not just watching to make sure that organizations are working in good faith, but also helping to remove any of the barriers to care or glitches in systems and supporting those things. So if I would recommend that the board keeps this. I don't know if there's any changes that you'd like to make or if you'd still would like to keep it.
Valerie, this is Fergus. One of the things that comes to mind here, while the quality of service, yes, but we alluded to it in some of the other, one of the other areas on the reimbursements and things like that, supporting the services, is the efficacy and quality of service provision across.
Ooh.
I don't, just another one of my bandwagon issues. Because I think there's some actors out there who are, unfortunately, we see it, are getting these grant funds, and there's no way they're able to provide those services, but nobody's really monitoring that in-house. And the good folks that have good morals and ethical standards are paying the price also.
Well, we also want to make sure that public funds are being spent judiciously, right?
Yeah,
So if public funds are being used to pay for a program, but the program is not, even if it's being implemented as it says it's supposed to, and with proper services, if it doesn't work, it doesn't work.
Erica?
Apologies. I just wanted to let everybody know, unfortunately, I have to jump off for another meeting. So I hope that doesn't mess things up in terms of quorum.
We do still have quorum. Thank you, Dr. Rist, for letting us know.
Okay, great. Thanks.
Thank you for your input, Erica. And Patrick, you're on mute. Go ahead.
Thank you. So is the idea here to have something that's independent from licensing boards when it comes to evaluations of the quality of things? I mean, are you thinking about involving specific licensing boards because they have standards in place that are usually within the ethics boards, or are you thinking about developing something totally different and independent of that?
Well, again, different, because it may not necessarily be the individual providers, or people who call themselves providers. Again, if someone says that they're a provider and they're not licensed, that's, another issue. But in previous meetings, I brought up the issue of people who are quote unquote coaches and essentially practicing without a license, but there's so much gray area there. The other issues, of course, come to, if there's maybe an example springs to mind. Let's say there is a crisis call that goes into an operator, and the operator runs through the checklist of different things that they have to go through, and they technically meet all the minimum requirements within that call. But if there's a way that they handle the call that doesn't necessarily, maybe it's the way that they were speaking to the individual, maybe it's something else that happened that doesn't protect the individual's safety. Yes, they maybe met the requirements, but they're not protecting the quality of care that the individual is getting, if that makes any sense. That's just something that I kind of pulled out of the air. I haven't received any complaints about that specifically, but that would be something that I would think would kind of in line with that quality of service provision, where they're checking the box and they're providing the service as they're required to, but maybe it's not what it needs to be. And we need to support a culture of continuous quality improvement and service improvement in a lot of places.
So quality of care, would that be, you're considering it as an organizational level or on a clinician independent clinician level?
It would really depend on the scenario, because if it was if it was for an independent licensed clinician, it would be through the licensing boards where it would be handled. But there are also, as we're looking through these different quote unquote community providers, so CHWs, peer recovery support specialists, behavioral health and wellness providers, how do we help the certification board and actually I believe the Nevada Board of Examiners for Social Workers or psychology. Sorry, that goes through psychology. Board of Psychological Examiners, building out regulations that help support quality of care and those feedback mechanisms. But again, there's organizational and systemic issues that could affect quality too. So it's, again, the board will support programs to evaluate and improve quality. It's not saying that the board will do it, but if there are things that come up, that the board will be willing to support that.
Great explanation.
Sorry, I was
No,
rambling.
No, I feel better about understanding it now. Thank you.
Okay. All right, any other questions about this? All right. This is the last one. Sub-priority, or this is priority 5, supporting local efforts. So sub-priority, collaboration and support for aligning efforts of local coalitions and agencies. The board will work to support and elevate the efforts of local and regional groups that are aligned with both the needs of the community and evidence-based or best practices. We are very fortunate to have some amazing groups in the region this board serves that does a lot of work in this area in an evidence-based manner. So really just saying we want to support and elevate them and not try to have anything duplicated or diminished because it's a local agency and not of a higher level. Thoughts?
Running a coalition, I support this, but I don't know if that's appropriate, but I just like it.
Anybody else? All right. Support use of opioid settlement or best use of opioid settlement funds. The board will support local government efforts to use those funds in a way that both meets their intended purpose of addressing the opioid epidemic, as well as meeting the needs of the community. Members of the board or the Rural RBHC may provide TA or connect TA being technical assistance, or connect technical assistance resources to local planning groups as able and appropriate.
And I'll speak to this since this is our specialty, but there's a lot of repetition that can happen if there's not a lot of, real planning going around this. So yeah, this is important to make sure that we're not wasting money. You know what I mean? So that's been a big issue. It's just replication and making sure that we're all on the same page. So we do a lot in our coalition meetings discussing, like the opioid settlement funds and things like that.
All right. So any board members want to see any changes to this or leave it as is? All right, not hearing any screaming and yelling, I'm going to go down to expansion of local behavioral health task forces. All right, so this has been a tricky one for me. So just as some background for some of the newer board members, when these positions being my job and my counterparts, particularly in the West, so Carson City, Lyon County, behavioral health specific task forces were built to target specific issues. As I started this work, I launched one in Elko, and we had some hiccups along the way, and ultimately it came down to we need more information regarding key issues that need to be hammered out. So we need to hammer out peer recovery support specialists, how they can be used, what they should be used for, et cetera. And I am doing some current work on that. And ultimately, if there's no, it always came down to who's going to do the work. What organization can hold the grant, who's best suited to do so, and what staff are we going to use? And when we don't have the staff, we can't do the work. So for the sake of not having meetings, just for the sake of having meetings, I shifted focus more onto the work of the coalitions and other local level groups that were already meeting and trying to add TA here and there. I do not have the behavioral health task forces directly mentioned in my scope of work this fiscal year. So I would almost recommend that we change this somehow. I'm not certain how. I don't know if you'd like to remove it. We already mentioned supporting the work of local entities up above in this particular section. So please, board members, if you have any feedback, let me know.
Valerie,
Sorry.
I'm sorry, Wendy. Valerie, if you could just scroll up to the previous section where you said supporting.
Yes,
Okay.
so this would be collaboration
Yeah.
support of local entities.
Okay. Okay. Go ahead, Wendy. I'm sorry.
No, you were exactly what I was going to say. I think it just should be. I think the collaboration has really been the key for that. So it almost replaces some of that. So that because we find that we collaborate so well with these entities. So with the behavioral health boards.
But I like this last priority is that the board is directing our Valerie to support integration and collaboration across at county level behavioral health. What I don't get the right wording for it. But a way for you to support the communities so that when you're going out there and doing that, they might call it whatever they want, but you're providing support. Go ahead, Brooke.
Sorry, I have a word that might fill in what you were trying to say. So this is Brooke for the record. Could we say to support capacity building of local behavioral health task forces? Or help to build the capacity? Because it's not so much that we need you to go around and start all sorts of new task forces, but you have a unique perspective that can help build capacity of those task forces.
Building of
Local
I wouldn't say existing because
and okay, so to support capacity building of existing local behavioral health groups and promote the creation of new groups as appropriate. Or new initiatives.
I don't like that the way you have it.
Okay.
Anybody else? Agree? Disagree? All right.
All right. Whew. Okay, and that is it. So our board
up everybody.
So our board members, Fergus, take it away if you want to do a motion or not.
So board members, we've been through this together. We've done this working live on the workplace here and the whiteboard. And we have the additions, edits and things. Would entertain a motion to accept that as our 2026 priorities. Need a motion on that.
This is Brooke O'Byrne for the record, and I move that we approve the 2026 priorities inclusive of the final edit notes in the final column.
Excellent motion. Is there a second for that?
This is Patrick Rogers for the record, and I'll second
Thank,
Brooks' motion.
thank you, Patrick. All those in favor say aye.
Aye.
Any opposed? Outstanding work, folks. Outstanding. Appreciate that. That helps. Okay. Valerie, you get those finalized and back out to the board members, if you would, please. So we have our final copy, if you would.
Will do.
And then let's move on into quickly here. It's 10 after the hour already. The proposed process and timelines for the bill draft request. We just want to touch on this initially, right, Valerie? As we prime the creative minds for the subsequent meetings as we determine our priorities for bill draft.
Perfect. Okay. And so I had sent this out to board members in an email and didn't receive any negative feedback. So essentially we have to have the BDR submitted, completed and submitted by September 1st of this year. So we want to make sure that we have an opportunity for working with stakeholders, hammering out the language, identifying different channels for BDR topic submission. So that being said, the proposed timeline. So phase 1, concept collection. The public call for proposals would open this week. And I didn't put an end date on this but we can also create one. But put out a public call for proposals. So I can use SurveyMonkey, I can use electronic flyer to distribute through various channels, but essentially asking stakeholders and members of the public to give us different ideas. The way we've done this in the past is we've collected some ideas. I've brought them to Fergus. We've hashed them out as far as what aligns with the board's priorities, which is also another reason why we did the priority update today, so that I can send that out with the call for proposals so people know exactly what you guys want to see. And then we go to the first hearing of proposals at a board meeting, which would be our next meeting. The final hearing of proposals would be in May. So that gives us 2 different board meetings where we can have an agenda item for hearing proposals. And then moving into phase 2, topic or concept selected by vote. That would be at the May 5th meeting. Phase 3, workshopping it. So you already have decided upon your topic, what you want to change with your BDR. And so we're going to open up communication with stakeholders regarding proposed BDR topic and feedback collection. So I usually attend different meetings, say, hey, this is what my board has selected to move with the BDR. Let me know what you think. Let's talk this out. I will present initial feedback to you at the June meeting. And then also within that timeline, I'd like to have at least one online workshop to hash out the specific components with stakeholders in the public. So making sure that we meet the needs of people who are passionate about this topic, make sure that we're doing it correctly. This has worked out really well in past years when we've had the opportunity to go through different language and get things hammered out a bit better. Phase 4, board approval. So you will review and approve the final bill language for submission at the July 7th meeting. If we can't make quorum or if timelines get pushed back somehow up to this point, we can keep that August 4th meeting, and that's when you can approve. And then phase 5, BDR submission. So that completed BDR form to be submitted by myself and Fergus after approval. So that could be as early as July 7th or as late as August 31st. And that is the proposed timeline. I did work in some wiggle room here so that if we can't, let's say we don't make quorum at the next meeting or the May 5th meeting, we can kind of shift things back a little bit and still make all of these goals and move through the process. Board members, any thoughts?
I like it.
Okay, I'm going to say March 5th through May 5th, or Oh, no, wait, I would need to get it on the agenda. So May or April 15th would be the closure of public call for proposals. I believe I do have to have specific topics outlined on the agenda, so that's why that would be pushed so much further forward.
Valerie, will that April 15th date, how will that interact with your next bullet there, the first hearing of proposals of April 7th?
Yeah, so any proposals that we get by the end of March or thereabouts, we can have at that first hearing of proposals, and then the final hearing of proposals would be May 5th.
Okay, very good. Okay. This too is listed as an action item. Board, entertain a motion if you like that timeline. It's robust. It's spelled out for us so that we know what's coming down the pipeline as we move forward in this. Remember, this is our one time to shine, really, with our BDR. We choose it carefully and make some impacts for the state of Nevada and our rules. So I'd entertain a motion if you're acceptable for this timeline as presented and edited live.
Chris,
Just for the record. Go ahead, Chris. Sorry.
Oh, I would make a motion that we accept this timeline and prepare to move forward with that and submitting our BDR.
Thank you, Chris. And for those new members that are on, Chris has also helped with our legislative committee when we've gotten close to the wire or we got to make things happen. So very knowledgeable in this process. Is there a second for Chris's motion?
Since I'm unmuted, this is Patrick, and I will second Chris's motion.
Thank you, Patrick.
Yeah.
All those in favor, say aye. Aye.
Aye.
Any opposed? Hearing none. We got it. Okay, Valerie, you got just a few minutes because we have to have public comment yet. Informational updates, if you can keep them relatively brief so we can be done by 3:30.
I will keep it very snappy. So I have been working on my scope of work for this year. Things that were not included in previous scopes of work. I'm focusing on doing some assessments as far as what's going on in the region regarding alcohol treatment, what resources are available, where the gaps are. It's an asset and gaps analysis. Doing a similar assets and gaps analysis regarding recovery-friendly workplaces and recovery-friendly communities. And also I get to pick up the suicide postvention project. There are postvention tools available that are more generalized to not specific communities. There are some that are available through the Department of Education for schools, but there are none that are really appropriate for organizations and businesses who may lose someone of their staff or the loved one of a staff member to suicide. So I was working with some local level stakeholders out in Elko to build a pilot that would be a little bit more kind of Elko centric, but could be easily made into a template that could be used in other communities. For those of you who are not familiar with the term, postvention describes the process and actions taken after the loss of someone to suicide, or quite frankly to overdose as well. And how that can be handled. So we want to get toolkits and stuff in place because we don't want people to have to try to figure out how to navigate that when they are already navigating some pretty heavy emotional stuff. I'm also working with the state on building out some sort of quality crisis system, 988 focused quality meeting to promote continuous quality improvement amongst the 988 system. And identify some of those gaps because we're already hearing feedback. I want to get the state players at the table, as well as our local stakeholders who are working with people who are in crisis and identify what we can do to fix it and fix it now instead of in a year. And so the state's game for that. We've got some good folks that we are building out an initial kind of planning meeting in a couple weeks, and then we're going to go ahead and launch that. Also coming up in a couple weeks, pulling some stakeholders together to identify how we can maybe best leverage the Rural Health Transformation Grant funding to build improved infrastructure, maybe surrounding most and fast programming that might include some ACT or AOT programming. We're not certain, but kind of pulling together some of the more clinical service providers at the moment to say, okay, what is the current menu of options that you have? And then what can we bring to law enforcement and the justice system? Because we want to have some more solid ideas in place before we approach them, because we know that their time is valuable and we don't want to muddy the waters. That being said, I'm going to go ahead and shut my mouth. Thank you very much. Any questions?
I will just go on record again and say, Valerie, we appreciate all the work that you're doing out there on behalf of this board and the folks within our region and holding it all together. Appreciate that very much.
Thank you.
Next, we will go to public comment. This is, again, you'll be limited to 3 minutes. And if someone would, from the public, there was somebody that was wanting to speak earlier, this would be your opportunity now. Just raise a hand so we can call on you, if you would, please. Any public comment at this time? Not seeing any. One last chance. Okay. And I want to just comment for the folks that are not board members that attend our calls routinely. We appreciate you attending and taking the time to attend these and see what's happening in the background and as we all work together going forward to create a better behavioral health system in rural Nevada. So I appreciate all your taking the time and input that you do provide. Not hearing any other public comment. I am ready for adjournment unless the board members have any other comments. Going once, going twice. Board members, thank you for your time today, and we will see you at our next meeting. All right, we are adjourned. Thank you, everyone.